Hello and welcome to the Bourne Report Deep Dive, a Bourne Partners podcast. I'm Chelsea Engel, marketing at Bourne Partners, and on this podcast we speak with leaders across healthcare and life sciences to explore the trends shaping the future of the industry. Today we welcome a guest from Outcomes Matter Innovation, or OMI. To kick off the conversation, I'll hand it over to our Director of Research, Don Hooker, who will introduce today's guest and guide the discussion. Don?
Well, thanks, Chelsea. Hello, my name is Donald Hooker. I am the Director of Research here at Bourne Partners. A consistent theme across virtually all of the research that we put out here at Bourne Partners over the past year or so has been the real need for U.S. healthcare to embrace value-based reimbursement. And this couldn't have been made more clear than by last month's report from CMS showing that U.S. healthcare spending has been increasing by over 7% in each of the past 2 years, well more than GDP, of course, and obviously at an unsustainable rate. To get deeper perspective on this topic, we're super excited to have a chance to have a brief conversation with Dr. Andrew Pecora, who is the Chief Executive Officer and Chairman of Outcomes Matter Innovations, or OMI. OMI is a rapidly growing vendor of technology-enabled solutions that help specialty providers make better clinical decisions at the point of care. So, Dr. Pecora, thank you so much for your time.
Thank you, Don.
Sure. So the idea of sort of value-based reimbursement is clearly not new. I think I have personally been following companies and vendors of various types of clinical decision support technologies for probably 20 years at this point. But yet here we are, 2026, still mostly in a fee-for-service environment. Asking a lot of the same questions. So I guess, Dr. Pecora, why have healthcare providers over the years been so resistant entering into value-based arrangements, and particularly in specialty care where OMI focuses? And maybe can you talk about some aspects of what OMI is doing that's unique?
Sure. So fundamentally, if you think about it, when people in healthcare hear the term value, their first concern is, oh, I'm getting cheap care, or I'm getting care that you're not doing everything you should be doing for me because you want to save money. And that permeates through the entire ecosystem. In specialty care, it's particularly heightened because you're dealing with not simple problems that have a long-term outlook to becoming serious problems. You're dealing with things like cancer, type 2 diabetes that's active, heart attacks, things of that sort. So the first issue is you must be able to make everybody comfortable in the ecosystem, that the care to be delivered is appropriate for the condition the person has, and you're able to deliver that care where you're guaranteeing the person's going to get the outcome they deserve, the best that medicine and science has to offer, and that it's going to be made more affordable for them. So how do you actually do that? How do you assure the patient, the doctor, and society that the quality of care will not be sacrificed by reducing the cost of care? And that's where OMI comes in. What we have focused on is first analyzing the points of resistance of why specialists in particular in the United States have not embraced value-based care. And then secondarily, what would patients, payers, and regulators care about if there is such a system where specialists are taking part in it? And so the first thing, just looking at some big numbers, if you look at total spend of care in the United States and you take out the administrative stuff, what's left behind is 80% is generated by specialists and 20% is generated by primary care doctors. So the vast majority of spend in the United States, the $4.7 trillion we spend, after you take out the administrative part, 80% of that is specialist. And yet, most of the efforts in value-based care have been focused on primary care. Here's another statistic that is not well known. When you look at specialists and you ask, okay, so of the 80% of spend that they're generating, where does that originate? And there's only two places. It originates in the doctor's office or in the operating room or on the hospital floor where the doctor is making a decision about how to care for a particular problem. And then the only other place is outside of that, in the home, transitions of care, whatever. Well, there was a study done that showed that of the spend, 80% is generated by the decision the doctor makes at the point of care, and only 20% is a consequence of what happens outside of the point of care. Not to say that's not important, but it's not where the most of the dollars are. So OMI decided to focus on specialists, because that's 80% of the spend, and at the point of care with a solution, technology solution that would address 80% of that 80%. And so the two fundamental problems in specialty care are the following. When you ask a specialist to change their behavior to result in reduction in total cost of care, they make less money. They're taking a pay cut to do it. And the hope is that 6 months, a year later, they'll get made whole on that pay cut they took and maybe get a return on it. But there's no guarantee. And secondarily, there's no way for that doctor, for his or her patients, to be able to show that those patients for which they changed their behavior to reduce cost of care, regardless if they make more money doing it or not, that those patients had the same outcome that they otherwise would have had the doctor done what they did before. So our solution that we built attacks those two key pain points. The first is we are able to calculate what the doctor's net income is for caring for a precise patient type for a period of time, and we guarantee them that they're going to be kept whole. So if I'm picking a number out of the air, if I made $1,000 to take care of a patient with a given disease for a year, and the total cost of care of that is $10,000, me being 1,000 of that 10,000, and I'm able to change something I do that total cost of care goes down to $5,000, I've saved $5,000 for the system. That's wonderful. But what happened in this example is my income for taking care of that patient is no longer 1,000. It's now gone down to 800. So I took a $200 pay cut to save the payer and the system $5,000, and I don't get anything for that. In our model, we're able to calculate that, and we say to the doctor, we'll give you that $200 while we wait for the accounting to be done, and that could be 6 months, a year later, so that that 5,000 that was saved, the payer keeps a piece, and OMI and the doctor get a piece, and from that piece, the doctor was already made whole by OMI, so OMI recovers that, and then the doctor and OMI share what's left of the shared savings. The patient benefits because their copay is lower, right? If you're paying 5% or 2% or whatever you're paying on your copay, or 10%, and some copays now are up to 20%, you'd rather be paying that 10% as an example on $5,000 than $10,000. So everybody wins here. Everybody wins. The second part is the following. OMI, through the technology, abstracts the clinical information for a patient. So in ophthalmology, it's preservation of vision. In oncology, it's survival. In rheumatology, it's improvement in your joint pain index score. Whatever is the appropriate outcome you're supposed to measure, we collect and measure that information. And so we're able to show at the end of a year to a doctor, to a payer, and to society that this doctor had 20 of their patients enter into this program. All 20 patients did exactly as you would expect them to do clinically. We saved this much money, total cost of care. Patients' copays were lowered by this much money. The payer reduced its cost by this significant percentage, 25, 30% on their spend. And the doctor not only was made whole, but actually was improved in their economics while they preserved the clinical outcome. So our solution to the big problem is Provide information at the point of care that enables a doctor to make a value-based care choice, knowing that they're not going to be adversely affected economically and their patient is going to have the outcome they deserve.
Wow, that's interesting. Maybe without maybe sharing your secret sauce too much here, can you give maybe some perspective on what are some of the to get to that optimal outcome? What are some of the sort of inefficiencies or pain points, if you will, that you find across the different medical specialties that OMI currently supports, or maybe stated differently, how much opportunity do you think is actually out there for improved healthcare quality and cost savings?
Well, first we'll talk about healthcare quality. It'd be nice to think that every doctor in the United States is equal and that every patient with a very precisely characterized set of disease characteristics gets the same thing and gets the same outcome. We know that's not true.
Yeah.
We know there's fairly significant heterogeneity in the quality of care in the United States, but that's not the big issue. That's an issue, but that's not the big issue. The big issue is among the vast majority of people that are getting the high quality care, meaning that they're getting the care that results in the outcome that science and medicine offers to be the best it could be.
Mm-hmm.
There's huge diversity in cost of care for getting the same outcome. It'd be like you walk onto a car lot and you see two of the exact same cars and they're exactly the same. And one car has a sticker price of $50,000, one car has a sticker price of $30,000. And you ask, why?
Yeah.
And the answer is, well, that's just the way it is. Which one do you want? Well, of course you're going to take the $30,000 car. Well, we have that in healthcare, but no one shows you that to make that choice. That's what we do. So we show the doctor, you know what? You can do this, that costs $50,000. You can do that, that costs $30,000. And they're exactly the same in the outcome you're going to get. And here's the proof of that.
Mm.
And now, what are you going to offer the patient? And not all the time, but most of the time, in our experience, across all the specialties we work in, the doctor is now willing to incorporate cost of care and say to the patient, you know, I used to do it this way, but I can do it this way, and it's going to reduce the cost by a significant amount of money. Your copay is going to go down. You're going to get the exact same good outcome. And then parenthetically, the doctor, by doing all of this, is rewarded by having better net income.
Yeah. Wow. And I guess one of the challenges, and you hit on it briefly, or you alluded to it briefly there, but just I guess one of the challenges I think we often hear about disruptive innovation and technology, particularly, is getting people to really fully use the technology to its full potential. So I guess there's a sort of a change management element to all these new technologies. How have you been able to sort of deploy your technology in a way that sort of actually gets the physician and patient to improve their behavior?
You're absolutely right. So, you know, the first step is you have to get the culture to be accepted. You need physicians and nurses to accept that in addition to the solemn duty they have as healthcare professionals to offer their patients treatment choices that are appropriate for a given disease, that they have to now accept that healthcare is increasingly unaffordable, and that if we want to maintain the availability of healthcare, which doctors and nurses do really care about that they have to now incorporate into their decision-making cost of care. So they weren't trained that way. You know, I went through medical school. I didn't get an accounting course. You know, like that's not how it's not how your brain works. You don't even think about what it cost. But now they need to think about what it costs. But it has to be done in a way where they do not believe they're sacrificing quality, which we talked about before.
Yeah.
So if you're able to overcome that hurdle, which OMI is successful at overcoming that hurdle, we're a physician-backed company. I'm CEO of the company. You know, I'm a triple E board certified physician. I'm a person that's known in my field. So I bring that credibility to the table as an individual, and my team brings that credibility. The second piece of this is, okay, we know change management is hard. No one likes to change. And no one wants to do one more click of a button or one more step. Show me a doctor that loves their electronic healthcare record. Show me one that loves it. They all
Yeah.
want to blow them up, right?
Yep.
And interoperability, we've been talking about this for 15 years, is still not real. Every EHR does everything it can not to allow for interoperability. I mean, it protects their business model.
Yeah.
So healthcare records, the simplest of things, if you see one doctor in one place and go to a different institution, you have to start from go, right? They can't go into the other EHR, take your records out, preload everything. That's what we do.
Yep.
We do the work. We do the lifting. It's far from perfect. We have a long way to go, but I do believe we're at a seminal moment in that government and business will come together around interoperability. I do believe patients will become the owners of their healthcare information, have ready access to it no matter where it is. And as this is all occurring, we are building the connective tissue, so to speak, informatically to be able to do what we need to do to make it seamless for the doctor and to make it so that the doctor does not have, and the nurse does not have to do double data entry or any of those things.
Yeah. You see, walked into one of my next topics, the interoperability. Hit on, I probably half answered my next question, but maybe just to hit on it a little bit further. So you're, engaging and sort of integrating and interoperating with various EHR systems and healthcare IT vendors. Do you all partner? How do you interrelate? How do you partner, I guess, or engage with these other EHR software vendors? Because you're right, there is a sort of a bad reputation out there for systems not being interoperable.
We partner where we can and where there's mutual interest, and we work around where there's not. And unfortunately, the majority is you have to work around because they're really not interested. That's not a universal statement, but it's a majority statement. I think that has to change over time. I don't see society accepting a whole lot longer that the domain and the ownership of the information resides in the EHR and only the EHR. I don't see that continuing.
Great. Well, maybe in closing, what's next for OMI over the next 3 to 5 years? Are there particular areas of the platform that you're looking to build out?
Yeah, well, we're scaling nationally. We did proof of concept the last 4 years. We've signed national contracts with some of the biggest payers in the United States. We're working to work with, the really big payer in Washington, and we're rising to meet the challenges faced by the ever evolving and changing healthcare landscape from the business side and keeping up with the change in science and medicine and integrating that into our technology. So we're laser beam focused on having the right tech stack to be able to scale and accommodate that. We're laser beam focused on evolving the business model to move from upside only to risk bearing in a safe way for providers. And we're laser beam focused on being a single source offering for all specialty care. Payers are getting a little tired of having a contract with a rheumatology vendor and a separate one with a GI vendor. We want to provide them a single stop shop to do all their specialty care and integrate with the ecosystem that's evolving in the United States healthcare system.
Well, great. I think we're all going to be patients at some point in the future for these specialty providers. So we're rooting for you. I think with that, I just want to maybe thank Dr. Pecora and the OMI team for their time, and we look forward to continue a dialogue with you. And please follow us at Bourne Partners at www.bourne-partners.com. Thank you so much.
Thank you very much.
Thank you again for joining us. To learn more about Bourne Partners, our services that we offer, our sectors we serve, and also our research, be sure to visit our website at bourne-partners.com. Have a great day.